Thank you very much. So very happy to be here. Very interesting conversation. I learned a lot. My presentation will be a bit more forward-looking because I was asked basically to talk about future drugs that will hopefully be at our disposal. Um, so it is important to understand that this disease is a consequence of a certain number of events that start with adipose tissue dysfunction and then insulin resistance, which creates a state in the liver. It's called lipotoxicity, basically inducing inflammation and liver cell injury. And that inflammation damages the hepatic cells in many different ways, as you can see here. But they all converge towards a pro-inflammatory milieu with cell death in the liver, which will then start a process of fibrogenesis. And this is how the liver gets damaged and how it gets fibrotic, with the end result, clinically speaking, which is, of course, cirrhosis. All this is important to understand because there are several levels of injury here, and then there's a sequence of events among these different levels of injury. And that becomes important when you start thinking about drugs, because basically what you can do is to hit at least three levels. Obviously, the very important one is to block fibrogenesis, because this is what is related to clinical events. But then you can also block the driver of fibrogenesis, which is steatohepatitis, so necroinflammation in the liver, or you can go even more upstream and try to control the metabolic dysfunction, which is at the root of the disease. Obviously, the effect of a drug, unless it's a very strong acting drug, will have to be to a certain degree at each one of these levels if you want to have an effective slowing down of the disease. So starting with this sort of paradigm, it is important to understand that now we have many drugs that target metabolic dysfunction. We have some drugs that might have pleiotropic effects related to anti-inflammatory effects, and we have, virtually speaking, no drugs that are direct anti-fibrogenic drugs. So the one important thing here to understand is that probably you have to hit at multiple levels, number one. And number two, you probably cannot be efficient just by controlling fibrogenesis or even by controlling the lipotoxicity. You have to somehow to control also the starting point of the disease, which is metabolic dysfunction. So the way you can prove in clinical trials that a drug works has been codified many years ago. And just as a reminder, these are long-term studies, involve many patients. You need histological endpoints to put a drug on the market. And the earliest you can do in registrational trials to demonstrate histological improvement is to do another liver biopsy after 12 to 18 months of treatment. And then the two things that need to be controlled according to the regulatory agencies are the activity of the disease, which is then called resolution of steatohepatitis, and fibrosis itself, ideally having a fibrosis reversal by one stage or more. If you have these two things happening, then the drug will receive conditional approval. This has also already been the case for two drugs so far, resmetirom and semaglutide. However, that approval is just provisional, conditional. So in order to get full approval, definitive approval, you will have to continue the study and prove that the histological benefits seen at the early time point will translate into clinical improvement, basically less clinical events in terms of cirrhosis decompensation or progression to cirrhosis. So this should be tested in very long trials, and then with many of them with a liver biopsy at the end of them. And then if you can prove that there is an impact on these clinical outcomes, then the drug gets definitive approval. No drug has so far reached that endpoint. Now, this is just a summary of the drugs that are most advanced in trials, in development programs for MASH. And you can see here those that had a phase 3 positive, resmetirom and semaglutide. We will know soon about lanifibranor, which is a pan-PPAR, quite similar to pioglitazone. And of course, the very promising drugs, which are the FGF21 analogs. The phase 3 is only started with these compounds. And then harnessing the power of GLP-1 analogs and creating dual or triple agonists. There are also phase 3 trials that are started or are already in advanced phase of planning with GLP glucagon analogs or triple agonists. So just a very short reminder of the results obtained so far. First, resmetirom. Uh, as a just a short reminder of the physiology of the thyroid hormones, because resmetirom is a tyromimetic. The T4 thyroxine is being automatically goes through passive transporters into the liver, into the cell, and then in the cell it gets, that's important, transformed into T3, and T3 is the active hormone. T3 will then migrate to the nucleus and exert the gene transcription events that are associated with thyroid hormones. There is a way of disposal of this, which is the transformation of T4 into reverse T3, which is an inactive form of the tissue. Now, all these drugs, so particularly the T3 active form of the drug, needs to bind to receptors. And there are two types of receptors, alpha and beta type of receptors, which have a different tissue distribution. And obviously, you would have to make sure that your drug reaches the liver and not the heart, or the bone, if you want to avoid symptoms induced by thyrotoxicosis. What is particularly interesting is that in states of inflamed and fibrotic liver, whether in humans or in animals, there is a reduction of the normal natural biotransformation of T4 into its active component, which is T3, and an increase in the transformation into the inactive thyroid hormone, which is again reverse T3. So giving a tyromimetic will bypass this enzymatic insufficiency and will hopefully restore a state of euthyroides into the cell. This is the principle of administering resmetirom. And of course, resmetirom has whatever drug you want to use, whatever tyromimetic you want to use for this indication, will have to be highly selective for the beta isotype of the receptor, so that you don't get, again, all the unwanted side effects associated with hyperthyroidism. So such a selective liver-enriched tyromimetic exists. It's called resmetirom. A few other ones are in development, but they are way behind. Resmetirom completed a large international phase 3 trial, which is the Maestro-NASH trial, with positive results. And this is the first time a drug has shown in a phase 3 trial positive results, both on the activity of the disease, you can see here on the left, and on fibrosis improvement. So in both cases, there was a nice dose-response relationship, and the highest dose did significantly better than placebo in terms of improving the activity and the fibrosis of the disease. It also improved the lipid profile, but it's not a metabolic drug. It doesn't do anything on weight. It doesn't do much on glycemic control as well. So it's truly a liver drug. It has some side effects, but honestly, from the experience we had so far in clinical trials, those side effects are really very moderate. So this is what brought this drug to approval. And of course, there's a study in cirrhosis that's ongoing, and the study in non-cirrhotics is continuing in order to prove improvement in clinical effects. Now, taking advantage of the effects of incretins, the second drug that received FDA approval and hopefully soon EMA is semaglutide. Semaglutide is a GLP-1 receptor agonist that is already on the market for diabetes control and also for weight loss. Now, what's interesting and a bit surprising about GLP effects is that the effects on the liver are not mediated through a direct effect on the liver, but rather through an indirect effect, particularly on the brain and maybe on the adipose tissue. So basically, this is how these drugs act. They induce weight loss. They might have effects that are independent of weight loss, but the improvement of the liver is not due to a direct effect on the liver. So to make a long story short, here again for semaglutide, a very large international phase 3 trial has shown that semaglutide has an impact on both the activity and the fibrotic part of the disease, with improvements much higher than placebo. Now, of course, these results were obtained after a long period of treatment, actually 1 year and a half, and at a very high dose of semaglutide, as you can see here, once a week, 2.4 milligrams. That's a dose that's higher than the one that's marketed for diabetes. it is the dose that induces weight loss. Weight loss was rather moderate here, 10.5% relative weight loss in this population, but it was a mixed population with many patients having type 2 diabetes. And we know that these drugs induce a lesser degree of weight loss in patients who are diabetic as compared to obese non-diabetic patients. Nonetheless, here again, remarkable results, better than placebo, positive on both the activity and the fibrotic aspect of the disease. And while you can, of course, argue that liver biopsy has limitations and maybe the effect we see on liver biopsy might not be real, it is important to remember that biomarkers of liver fibrosis also improved clearly, as you can see on this slide here, where they're talking about liver stiffness or serum biomarkers of established fibrosis or biomarkers of fibrogenesis like ProC3. They all improved in the active arm versus the placebo arm. So probably the antifibrotic effect is real, but it takes a long time to achieve it. So you have to treat for at least 1.5 years. Now, based on the fact that a dual agonist might have different effects, either stronger or simply different effects than the monoagonist GLP-1, there was a lot of interest in developing dual incretins, and this is an example of one that hits both the GLP and the GIP receptor. So GIP is a hormone produced again by the pancreas, and it acts pretty much, and the cells of the duodenum, and it acts pretty much like GLP. So it is somehow synergistic with GLP. It might have some effects, as we have seen on a cartoon that I'll show again, on the adipose tissue, improving adipose tissue dysfunction. So, and it induces a weight loss that is at least equal or even higher than the one achieved with semaglutide. So it makes sense to test it in steatohepatitis, and this was done in a phase 2 trial, 52-week trial. You can see here around 200 patients were included, and the effect was quite clear on a resolution of steatohepatitis with no worsening of fibrosis. This was the main endpoint. And then we don't know very well about the effect on fibrosis. This was not tested because it wasn't the primary endpoint. So for the moment, this is unproven statistically, but from the numerical differences, despite the lack of a dose response, we can assume that probably in a larger trial, maybe a longer trial, there will be a significant difference versus placebo. Some of the paradigms we thought that were always valid have been put into doubt with the results from this small, admittedly small trial, like the fact that there is always a relation between weight loss and improvement in fibrosis. It didn't seem to happen in this particular trial. So the jury is still out for this molecule, but it's normal. It was only a phase 2b trial. Clearly, there is efficacy, but probably you'll have to push the trial longer and with a higher number of patients if you want to see a result. Now, another type of dual agonist has been tested both for diabetes, obesity, and now for steatohepatitis, which are dual agonists of both GLP and glucagon. So the idea of using glucagon, and maybe I can show you again this photo here, is that in contrast to GLP-1 receptor agonists, glucagon acts directly on the liver, in addition to other sites of action. But it does act on the liver, and what it does is that it increases mitochondrial biogenesis, and it replaces the bad mitochondria with healthy ones, and it increases the disposal of fat, of fatty acids in the mitochondria through beta oxidation. So it has, in addition to the weight loss, a direct effect on getting rid of the fat from the liver. So that is something that might be an advantage over mono GLP-1s alone. And this was tested in a trial in steatohepatitis. And you can see here that the trial was quite complicated, a phase 2 trial, international trial as well, 300 patients, with a very slow dose escalation program that probably had something to do with the results, because patients in the end were only exposed for half of the duration of the trial with the maximum dose. Nonetheless, the results were positive in terms of the primary endpoint. So this was a sort of a pilot trial, proof of concept trial. So it's not the approvable endpoints that were tested here, but rather some sort of aggregate of activity in the liver. As you can see here, 2-point reduction in the inflammatory score without fibrosis worsening. And indeed, the active drug worked better than placebo, as you might expect from this additional action of disposing the liver fat through beta oxidation. The disappointment comes from the fact that there was no clear dose response in this trial. The response on liver enzymes was quite clear. And if we go a bit further, so that was not the primary endpoint, always have to be careful trying to make any conclusions out of draw any conclusions out of that. But if you look at the regulatory endpoints here, which are on the right, resolution of steatohepatitis or decreasing fibrosis, there were differences versus placebo that suggest that the drug is active, but since those were not tested formally for statistical significance, we cannot conclude anything from this data, but probably it works as well. So I would end up with another example just to tell you how much this field of incretins is actively being investigated right now. There are at least 3 or 4 other GLP glucagon compounds, dual agonists, and this is one of them, pemvidutide. These, although they are all agonists of these two receptors, they differ in the way of the pharmacologically speaking, the way they were built, and they also differ in their respective potency for the two receptors. So, for instance, pemvidutide is a balanced 1-to-1 GLP glucagon, whereas the previous one was a totally unbalanced 9-to-1 in favor of GLP. So this study with pemvidutide has been published recently in the Lancet. It is a US study, and you can see that the drug was very effective. Those are very powerful drugs in terms of anti-steatogenic effects. But here it shows that this goes together with an anti-inflammatory effect. Resolution of MASH was clearly more active in the pemvidutide arm, and the effect on fibrosis was only seen and documented through digital pathology. You can see that these effects, particularly the effect on activity, was seen despite a strong weight loss, contrary to other drugs. So this probably is a good indicator of the potency of the glucagon receptor itself. Again, very strong ALT reduction. And this drug might be interesting because it can be given without a dose escalation program, which is, of course,
Vlad,
makes it more.
we're going to have to ask you to wrap up. We're going to need to move to the
So
next
I'm going to
session.
wrap up with the most promising drugs, which are the FGF21 analogs here. Very different compounds in their pharmacology. The ones that entered phase 3 here have been acquired by Big Pharma, the ones that are shown here. So those drugs have a quite spectacular, at least in phase 2, so we have to be careful, efficacy in terms of fibrosis improvement, in terms of resolution of steatohepatitis. And these are the first drugs that have hinted to a possible anti-fibrotic effect, even in patients who have cirrhosis, as shown in this very nice study from the New England Journal. And then next year, as I told you, we'll have the results from a pan-PPAR agonist, which is lanifibranor, which had very encouraging, which is an oral drug, like resmetirom, in contrast to all the other ones we discussed, had very interesting results and promising results in phase 2 trial. So we will see the results of that next year. So my last slide is about the fact that since these drugs are all different in the way they target the liver and the metabolic dysfunction, we might be reaching a point, hopefully in the future, when we can do individualized therapy depending on the patient phenotype and the type of effect that we want to achieve. So there are important remaining challenges here. Obviously, improve awareness and diagnose advanced disease in these patients, identify them with biomarkers without the risk of, without the liver biopsy. And all these trials have told us that those are long treatments, and we have to predict non-response so that we don't continue the drug in people who are non-responders, and also determine whether it's all about weight loss or whether there are some weight loss independent effects. So in order to do that, we have to do clinical trials, and we have to include patients or refer patients in centers that are participating in clinical trials. Thank you.